Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we're looking at the complex relationship between mental health problems and problematic alcohol and other drug use, with the emphasis on commonly used illicit drugs and the role rural doctors can play in helping manage these conditions and finding appropriate support for patients who experience co-occurring disorders. Approximately 90% of Australians 14 or older have consumed alcohol, and 43% have used an illicit drug at some time in their lives. During the last year, roughly 80% of Australians aged 14 or older consumed alcohol, and 16% used an illicit drug. While the majority of people who use alcohol and other drugs are not dependent, approximately 1 in 5 Australians currently drink at risky levels, and around 1 in 20 Australians meet the diagnostic criteria for a substance use disorder. The rates of substance use are significantly higher amongst people suffering problems with their mental health. Welcome Paul Dessauer. Paul's been working in the field for 19 years, involved in delivering outreach services for people who are dependent on illicit drugs, including projects which specialise in working with people who have co-occurring mental health disorders. Paul, what are the most prevalent mental health problems that may be associated with problematic substance use?
Well, there are a number of mental health problems beyond dependence and addiction that correlate heavily with problematic drug use. People with a history of trauma or disadvantage appear to be more vulnerable to becoming dependent on drugs, and they are also more vulnerable to being diagnosed with a mental illness. So we do have a pretty complex little nest of feedback loops going on here. But in terms of drugs and mental health, a lot of the media attention we see is on psychosis. And the most prevalent problems we actually see amongst people who use drugs are to do with anxiety and depression. There's very little focus on those sorts of issues in the media. We also need to be cautious when we talk about cause and effect in this area. When we survey participants of our needle and syringe exchange program in Western Australia, about 70% of people accessing that service report symptoms of mental illness. But when we drill down a bit and look at the actual symptoms they're reporting, 80% or more of these people are talking about experiencing depression and anxiety. And we have to remember that experiencing symptoms of mental illness doesn't mean that you have a mental illness. In this case, it may just be a sign that you're living in circumstances that are depressing and that provoke anxiety. And I'd suggest to you that there are life circumstances in which if you're not feeling those things, that's when something's wrong with you. We know that some drugs can induce acute psychotic episodes, and I guess methamphetamine's the best example of this, if I put inverted commas around the word best. When we work with people who use methamphetamine, the vast majority of them never suffer a psychotic episode. And amongst people who use methamphetamine regularly, the problems that are reported most often are to do with mood regulation, dysthemia, anhedonia, and depression. Those on a population level, those sorts of problems are far more prevalent.
And just how common is non-medical drug use amongst people with a diagnosis of a serious or persistent mental health disorder?
Substance use is far more common amongst people with a diagnosed mental illness than it is amongst the general population. And when I was working in projects based on campus at Greylands Hospital a few years ago, it was estimated that more than 60% of inpatients had ongoing illicit drug use as a complicating factor in the treatment or progression of their illness. When we include alcohol and tobacco use, more than 90% of inpatients are people who are using drugs. So drug and alcohol use in that sort of population is not the exception. It should actually be considered the normal expectation. During the last year, roughly 80% of Australians aged 14 or older consumed alcohol. About 16% of Australians over the age of 14 used an illicit drug in the last year. The vast majority of people who use alcohol and other drugs are not dependent. Even with a drug like ice, which has a reputation for being highly dependence-forming, about 45% of the people who used that drug in Australia in the last year did so only once or twice. It's only about 20% or so of people using methamphetamine who are using it once a week or more often. They're the people we would think of as being dependent. and we tend to see more methamphetamine-related harm in that population. So although most people don't become dependent on drugs, about 1 in 5 Australians currently drink at risky levels, and about 1 in 20 Australians meet the diagnostic criteria for having a substance use disorder. So even if you're working in general practice in the community, you really need to be paying attention to substance use as part of your normal assessment and management and treatment of any patient. We really should be thinking of this as business as usual, not something out of the ordinary.
What do we know about the relationships between the use of the most common illicit drugs, such as cannabis and methamphetamine, and symptoms of mental ill health?
We definitely know that drug use can increase people's risk of experiencing poor mental health, but we also know that people use substances to regulate their mood and to manage how they're feeling. So once again, this relationship isn't a one-way relationship. It's bidirectional. It's highly complicated, and there are ongoing feedback loops, which I'll probably talk about in a bit more detail later. There is a definite association between cannabis use and lifetime risk of psychosis. All of the international research evidence is showing that more and more clearly, but what that association means is less clear. One of the reasons for that is there are these terribly annoying people called ethics committees who won't allow us to do the sort of research that might tell us, what's going on there. If someone has a diagnosed psychotic disorder, then cannabis use tends to make their symptoms worse, and it tends to worsen the progression of the disease over time. And I'll talk a bit more about that in a bit more detail later on. Methamphetamine is the most commonly used illicit substance in Australia, apart from cannabis, and there is definitely an association between methamphetamine use and risk of experiencing psychosis. Methamphetamine can provoke a sort of psychotomimetic state, and when someone is acutely experiencing psychotic symptoms related to methamphetamine use, it's functionally indistinguishable from someone who has schizophrenia who's in frank psychosis. The behaviour is identical. You can't really tell the difference. I guess the only way to tell the difference is to keep that person somewhere, is to calm that person down and reassure them, medicate them if necessary, treat any physical toxicity if it's methamphetamine related. But in terms of the behavioural stuff and the problems with psychosis-like symptoms, you really have to wait until the methamphetamine has worn off, wait a few days. If the person doesn't have a strong underlying vulnerability to psychosis, they'll generally recover within a few days of abstaining from methamphetamine. They may still be a little odd, but they won't be reaching the diagnostic criteria for psychosis anymore. We've got a pretty good idea of why meth does this. We know that dopamine is heavily implicated in the symptoms of psychosis. We know that when someone who has a psychotic disorder like schizophrenia is acutely psychotic, they have elevated levels of dopamine in some parts of their brain. We know that all modern atypical antipsychotics work by blocking dopamine transmission and dampening down dopamine release. Methamphetamine releases dopamine, serotonin and noradrenaline into your brain. The way that methamphetamine works on dopamine is that it causes your brain to release more dopamine. The methamphetamine molecule fits into the reuptake pump for dopamine. So normally when your brain releases dopamine, it releases tiny measured little squirts. They cross the synaptic clefts, they engage with the dopamine receptors. When they finish doing their job, they're sucked up by little reuptake pumps and they're stored away safely in vesicles in the neuron. When methamphetamine gets into that reuptake pump, it doesn't just block it in the way that an SSRI does, it actually reverses its flow. It's kind of like turning your vacuum cleaner on to blow instead of suck. And so instead of your brain releasing dopamine in these tiny measured doses, the reuptake pumps are kind of like spraying it around like a fireman's hose. You see an acute spike in dopamine. This accounts for some of the sort of behavioural problems we see when people are using methamphetamine to excess. Interestingly, there is a study going on in Western Australia at the moment. There's a couple of emergency departments collaborating in this now where drug-related presentations are being examined toxicologically in a lot more detail than they normally would be. When bloods have to be taken as part of the person's treatment or a cannula has to be inserted, an extra sample's being taken and it's being analysed with LCMS testing. And this testing can identify every single drug the person has in their system and it can quantify the amount in their plasma. And the interesting thing we're seeing in terms of methamphetamine-related presentations is that when someone presents and they're having heart problems or they're suffering stroke or these similar sorts of physical acute emergencies, their dopamine levels are very high, their adrenaline levels are very high, the plasma levels of methamphetamine are high. So that they've basically suffered a toxic overdose of the drug. Interestingly, when people are presenting in emergency departments with behavioural disturbance, with hallucinations or delusions of persecution or other sorts of anxiety, other sorts of psychosis-like symptoms, the plasma levels of methamphetamine are not actually that high. They tend to be rather mundane looking. And we think what this is doing is actually supporting some of the anecdotal evidence we have, which is that methamphetamine-related psychosis tends to occur in people who've been using chronically or have been binge using. And we think that it actually has a lot to do with sleep deprivation, with malnutrition, with dehydration. These are all risk factors for developing psychosis-like symptoms. And it's probably because the person's brain has spent a long period of time artificially elevated into an alert state, into a fight or flight response.
You mentioned that there's a strong association between cannabis use and psychotic disorders. Does cannabis use cause psychosis? And what does the evidence say about this relationship?
The evidence clearly shows that there's an association between cannabis use and lifetime risk of psychosis, but the evidence around causality is a lot less clear. When we ask a question like, does cannabis use cause psychosis? I guess the answer is yes if, or it might be no but it's going to be a messy answer. When I first started working in the mental health system and started getting access to patients' files, one of the things I found most interesting was the number of patients who had changed diagnoses over time. So people who have a long history with the mental health system will have quite thick files, and sometimes they have a drawer full of these files. And I'd be looking at patients' histories and I'd see someone who'd presented in a first episode or early episode psychosis, and they'd been diagnosed with a cannabis-induced psychotic episode. And after a few months or years of them presenting, quite often another doctor had removed that diagnosis and changed it to schizophrenia or to some other form of chronic psychotic disorder. That doesn't mean either doctor was wrong, of course, because we diagnose mental illnesses by symptoms, by clusters of symptoms. And if the patient is presenting with a different cluster of symptoms, then we may end up putting them in a different diagnostic category. So there's a big difference between how we diagnose a physical illness and a mental illness. The organisation I work for now runs very low threshold health clinics that are designed to engage people who are currently injecting drugs. They're co-located with our needle and syringe programs and in our outreach needle and syringe programs. When my nurse practitioner tells me that one of our consumers has hepatitis C, I know that they've got hepatitis C because she's done an antibody test and we've detected the antibodies for the virus in the person's system, which of course doesn't necessarily mean they have hep C. It just means they've been exposed to it. I think about 25% of people who have antibodies in their system aren't actually actively infected with the virus, which is a very important thing to tell someone when you get that test result. You really need to do a PCR test, and of course that detects the RNA of the virus. And so when we have a positive RNA result, a positive PCR test result, we know the person has hep C because we've detected the discrete disease-causing agent that is circulating in their bloodstream. When we diagnose someone with schizophrenia or bipolar disorder, we're not doing it based on a blood test. We're not detecting a discrete disease-causing agent because there isn't one. There isn't a thing that causes it. We know that there are familial and genetic risks for some of these disorders. We know there are environmental factors, things in people's physical and social environment that influence their risk. And we know that, when we talk about things like someone's propensity towards psychosis, we're talking about an interaction between their genes and their environment. So if we look specifically at schizophrenia, the prevalence in most populations on the planet hovers somewhere around 1%. But if you have a first-order relative who's diagnosed with schizophrenia, you have a 16% chance of being diagnosed yourself. If you have an identical twin brother or sister who's been diagnosed with schizophrenia, you now have a 50% chance of being diagnosed yourself. So there's obviously a strong genetic loading. This is something that runs in families. But I can flip that last statistic on its head and say you can have a genetically identical brother or sister who shared the womb with you, and presumably shared a lot of your early environment. They might be diagnosed with schizophrenia. You still have a 50% chance of not being diagnosed. There are other things going on. We know what some of these other things are. Some of them are quite subtle. If your mother contracted influenza during a specific week during your pregnancy, you are statistically significantly more likely to be diagnosed with a psychotic disorder later in life, regardless of your family history. And we think we even know why that happens. There's the time period in gestation where this window of risk is while a lot of the major dopamine-bearing pathways in the brain are being laid down, and influenza infection in the mother appears to interfere with the neurogenesis of that in that part of the brain development. There are some other factors that we know increase risk of being diagnosed with a psychotic disorder. The more invasive or intrusive treatment there is at birth, childhood trauma and neglect, migration and social dislocation seem to increase risk quite significantly. Homelessness seems to increase risk of diagnosis of these sorts of disorders as well. So does cannabis cause schizophrenia or other psychotic disorders? Or is it perhaps another risk factor? On a population level, we don't see increases of diagnosis in schizophrenia over historical periods where cannabis consumption has increased. We think if it had a significant causal role, if it generated novel cases of schizophrenia in people who wouldn't otherwise have been so diagnosed, that we'd be seeing that in our epidemiology. There are studies that compare small districts and that show a correlation between rates of cannabis use in a certain suburb and rates of diagnosis, but they tend to be suburbs where we see clusters of lots of the other environmental risk factors that I've mentioned, and it's very hard to work out how you can control for those sorts of confounders. When we look at really big population-based studies and meta-studies, the association is much harder to pick up. There was a series of studies done by Arndt and his colleagues in Denmark. They reviewed millions of person-years of records, and what they looked at was family risk factors for a diagnosis of cannabis-induced psychosis or for a diagnosis of schizophrenia. And they started doing this because they'd identified the same thing that I had when I first started flipping through files, which was that most young people diagnosed with cannabis-induced psychosis are re-diagnosed within 5 years to having some other disorder. And what they found was absolutely no difference in family history for patients who've been diagnosed with cannabis-induced psychosis and patients who've been diagnosed with schizophrenia. And later studies they did showed a similar sort of congruence in family history for people diagnosed with cannabis-induced psychosis, schizophrenia, or bipolar disorder. And what these researchers suggested was that none of these were actually valid diagnostic categories. If you research the literature, the recent literature, you'll see there are a lot of discussions going on about the end of schizophrenia as a diagnostic category. I think what the evidence is suggesting is that we should be moving towards the idea that there is a spectrum of risk to psychosis, and that when people present with a certain set of symptoms, we've been putting them in one little category. The other conclusion of these studies was that cannabis-induced psychosis was not a valid diagnostic category. It was just a form of schizophrenia, and that when we diagnose someone in their early episodes with cannabis-induced psychosis, what we're actually doing is detecting an early case of schizophrenia. Having said that, people who are prone to psychosis are at much more risk of problems associated with cannabis than people who aren't. It appears that probably 2% of the population are at serious risk of suffering a cannabis-induced psychosis. They tend to be people with strong family histories of psychotic disorders. 98% of human beings will never experience a psychotic episode, even if they smoke lots of cannabis. That doesn't mean it's harmless, of course. It doesn't take a doctor to know that burning leaves and inhaling the smoke might not be that great for your respiratory health. And we do see people who become, about 10% of people who smoke cannabis become dependent on it, and amongst people who are dependent on cannabis, we see much higher rates of depression and anxiety disorders than we do amongst people who aren't dependent on cannabis. On a population level, they're the mental health problems that are most heavily associated with cannabis. So to try and understand what's going on with cannabis and psychotic disorders, we know there are more than 80 cannabinoid chemicals in cannabis smoke, but the most significant ones in terms of psychoactive effects and effects on people's mood and mental state are THC delta 9 and CBD or cannabidiol. THC is what makes people feel stoned. It's what's rewarding about smoking cannabis. It's the thing that will lead someone to becoming dependent on cannabis. It can provoke anxiety or transient psychosis-like symptoms in excess. Cannabidiol, CBD, is actually a very potent anxiolytic. It reduces anxiety, and it functions as an antipsychotic. So we have these two chemicals in the plant which can provoke wildly different symptoms. When they're in the right balance for the person, then smoking cannabis tends to be rewarding, and it tends to relax people and make them feel calmer. Both of these chemicals are produced from the same precursor chemical in the plant. And when people selectively breed to get a strain of cannabis which produces a large amount of THC, what they're in effect doing is breeding a strain of cannabis that has a lower level of CBD. This is why we think that some of the modern strains of cannabis might be worse for people's mental health than the traditional stuff that we see. A lot of the cannabis that's grown for the black market is grown in underground hydroponic laboratories, and you can control the environment completely when you're growing hydroponically. One of the things that growers tend to do is pick a strain that is very high in THC, because that makes the product very rewarding and it means they'll sell more of their product. But compressing the photo period also tends to increase THC content and reduce CBD content in the product you're producing. So if you've read news articles about cannabis getting stronger, yes, generally speaking, the stuff that's available on the black market has a higher THC content than it did 20 or 30 years ago. It's not because people are genetically engineering the plants or because of chemicals they put in the hydroponic water. It's to do with these sorts of adaptive changes in the plant. There is a short-term mental health problem that just about anyone smoking cannabis can experience, and it's typically called greening out or whiting out by people who smoke cannabis. And it's basically caused by ingesting too much cannabis in one go. It's a lot more common when people eat cannabis products than when they smoke them, because when you smoke cannabis, you feel the effects pretty much immediately, so it's very easy to titrate the dose to the effect that you want to have. When you eat cannabis products and they take 40 minutes to an hour to start taking effect, and your liver gets to metabolise the cannabinoids and change the balance of chemicals that's getting into your bloodstream a bit, it's much easier for people to accidentally have too much. Greening out occurs quite frequently if someone has drunk reasonably large amounts of alcohol and then smokes cannabis as well. And the typical symptoms of greening out include nausea and emesis, tachycardia, sweating and headache, anxiety and fear, panic attacks, immobility, and sometimes we see transient psychosis-like symptoms, so delusions or hallucinations, more typically sort of derealisation and depersonalisation. People often feel they have to lie very still. They feel that if they move, they're going to be very ill. They're usually breathing quite deep and hard, and they're generally quite terrified, especially if they've never heard of this sort of response happening before. The symptoms usually resolve within 40 to 60 minutes without any serious harm, although that can take a lot longer if the cannabis products were eaten. Generally, when someone's experiencing this, the best thing we can do is try and reassure them, try and give them water to sip. If very large amounts of alcohol are involved, then the risk of aspirating vomit and choking is probably higher when someone's having this sort of response. And I would imagine that if you had a serious risk of mental illness, that this sort of experience might not be very good for you. Yeah.
You've mentioned that people who have experienced disadvantage and trauma tend to be more vulnerable to these sorts of problems. How does the experience of disadvantage and trauma impact upon someone's mental health and on their substance use?
There are social and economic determinants of health, we all know that, and that applies to people's mental health and to their substance use as well. There are complex feedback loops between these sorts of things as well. We know that, for instance, homelessness is heavily associated with substance dependence. It's also heavily associated with problems with mental health and with serious and persistent mental illness. That doesn't mean that substance use causes homelessness. It doesn't mean that mental illness is the reason the person is homeless, although obviously these can be factors that contribute. Being homeless might be contributing to someone's symptoms of mental illness, or might be contributing to them developing more problematic patterns of drug use. Someone is experiencing life circumstances that they find unbearable, and they don't believe that they have the resources or the ability to change those life circumstances. The one thing that they can almost always afford to do is change the way that their brain is perceiving their circumstances. That's as simple as walking into the local bottle shop. So part of this correlation is just the fact that people are self-medicating for a range of other issues, and I'm sure I'll talk about that a bit more a bit further down the track.
How does the stress vulnerability coping model help us better understand and respond to these types of co-occurring problems with substance use and mental health?
The stress vulnerability model was originally developed by Zubin and Spring in 1977 in an attempt to improve understanding of what prompts acute episodes of psychosis and schizophrenia. But over the years since then, it's the name's changed to stress vulnerability coping to more accurately reflect what we're talking about. And the model's been adapted to more broadly describe factors that increase or decrease vulnerability to any symptoms of mental ill health. I guess most people have a model of mental health and mental illness that kind of looks like there's a little bubble off to one side, and that's got all the crazy people in it. And then there's a much bigger bubble which has all of us normal, healthy, sane people in it, as though we're talking about discrete, different populations. And what Zubin and Spring pointed out is that it's far more accurate to think of mental health and mental illness as a gradient. You can imagine a pyramid or a slope, and we're all positioned somewhere on that slope, higher or lower. We all have a level of vulnerability to symptoms of mental illness that decides where we are on that slope. Some people are extremely psychologically and emotionally robust, and you can put them under enormous stress and they just seem to keep functioning. And some people are chronically unwell, and they tend to be the people who get diagnosed with a serious and persistent mental illness. But most of us aren't at either extreme. Most of us are positioned somewhere on that slippery slope in between those extremes. We each have this individual stress vulnerability threshold. There's an amount that we can cope with, and it's when we push past that amount that we start to see symptoms of mental ill health emerge. That individual level of vulnerability or level of resiliency, as I mentioned earlier, has a lot to do with your genetics. You know, we know that, for instance, there are variants in the genes that code for serotonin that heavily influence your ability, your risk of being diagnosed with post-traumatic stress disorder. They don't cause post-traumatic stress disorder, but if you're in a highly stressful situation and you have those genetic variations, you are slightly more likely to be diagnosed with the disorder. There's things like insult and injury that you might have suffered in utero or perinatally or in your early childhood that can greatly increase or decrease your vulnerability or your resiliency in this regard. So these sorts of risk factors and protective factors move us up and down the gradient. I've already mentioned a few. We see higher incidences of mental health problems in people who've experienced serious trauma, serious disadvantage. We see it in people who are currently experiencing trauma. We see it more commonly in people who have migrated, who are refugees, especially if they're migrating away or running away from a traumatic situation, but also if they're not, if they don't have good social supports in the country they move to. Social isolation, social dislocation, repeated social defeat all seem to increase risk as well. If you're subject to chronic stress, or if you're suffering acute stresses, if you're sleep deprived, malnourished and dehydrated, then you are more vulnerable to symptoms of mental illness. So whatever your sort of natural level of vulnerability is, based on all of those previous history things that I've mentioned, your level right now is changing all the time. You know, if you had a good night's sleep last night and everything's going pretty well in your life, you're probably going to be able to tolerate more stress than if everything's been getting too hard for the last 3 weeks and you haven't slept at all and you're lying awake at night stressing yourself, yeah? Stress and depression are adaptive. They're things that evolved long before humans did as a way of motivating an organism to change things in its environment. When we're under acute stress, we have this chemical cascade of cortisol and adrenaline and dopamine and lots of other neurotransmitters and hormones that prepare our body very well to run away from something or to fight it. And sometimes that fight, flight or freeze response just makes us freeze on the spot. You know, these are really useful adaptations if you're a mouse, because the main source of stress in a mouse's life is aggro from other mice, getting eaten by large ambush predators like cats. So if they're the main sources of stress in your life, then fighting back or running away or pooing yourself and playing dead are actually really useful ways to respond. They're quite likely to keep you alive. Not so useful for humans. Most of the stresses we experience we can't punch or run away from. Pooing your pants and playing dead doesn't seem to help in any social situation I've been on. The other thing is that we're subject to chronic stress. You know, there's a big difference between mice and us, and one of the differences is that mice don't lie awake at night worrying about what happened yesterday, and I don't think they do, and I don't think they lie awake at night worrying about something that's going to happen next week either. So this stress response adapted to deal with acute threats to your survival. It gets activated whenever we're under stress, and it's not healthy to spend long periods of time in that stress response. It's not healthy mentally or physically. And in modern life, a lot of humans are in that position. And there are life circumstances that can greatly increase your exposure to that sort of stress. There are some really strong environmental predictors of mental ill health. These are things that, quite regardless of your genetic predispositions or your early childhood experiences or anything like that, can increase your risk. Conversely, we know that good psychosocial supports in the community, a sense of belonging and inclusion, having something worthwhile and engaging to do with your time. It doesn't have to be paid employment, it just has to be something rewarding that takes up some of your day. All of these things are highly protective. And as I said before, this isn't rocket science, it's just operating with an understanding of Maslow's hierarchy of needs. If we aren't fulfilling the bottom rungs of that hierarchy, we shouldn't expect that we'd be operating very well on the higher levels. So in mental health or in alcohol and drug work, we need to be trauma informed in our work. And just generally speaking, this stress vulnerability coping model is a really good way of framing your thinking. It's extremely useful because it moves our emphasis away from trying to reduce someone's drug use or trying to medicate away the symptoms of mental illness, and it realigns our focus on attempting to address the underlying drivers of that distress. One of the most important things you can do as a doctor, if you care about these issues, is to role model appropriate language and behaviour for your colleagues. All workplaces have a workplace culture. The language we use, the attitudes we exhibit, they shape that culture. And doctors are incredibly influential within their workplaces in this regard. I know that you wouldn't want your staff to discriminate against people based on their nationality, their ethnicity, their religion, their gender, their sexuality. You can create a welcoming and non-judgmental workplace, and one of the ways to do that is by example. When you're working with people who use drugs, please try not to make assumptions based on preconceptions. Please be aware of your language and your manner. You need to demonstrate you have empathy. You don't actually have to like someone to do that. You just have to behave like a professional. Be polite, be respectful, and listen. And if you really listen to your drug-using patients, you're probably going to learn quite a lot. Most of all, understand that people take psychoactive drugs for a reason. They take them because they work. These drugs change the way you think and feel. I've said earlier on that a lot of the people I meet who have the most problematic patterns of drug use have serious problems in many other domains of life. The drug use is some sort of coping strategy. It might not be the greatest coping strategy in the world, Drugs work, but they work for a very short period of time and then they wear off. They create problems of their own as well, but they are always serving a purpose. Substance use always has subjective benefits as well as harms. If the only thing the person was experiencing was negative, then they wouldn't need drug treatment professionals to stop taking the drug. They'd just stop doing it. Try and work out what that purpose is. If you don't know what purpose the drug use is fulfilling, what holes it's plugging, it's going to be impossible for you to offer useful advice. Thank you very much for your time today. I hope the issues I've been discussing and the suggestions I've made are useful in your work. Please feel free to get in touch with me if I can be of use in any way.